Good evening, everybody, and welcome to this ESSO webinar on improving cancer surgery outcomes and research. What is the patient perspective on surgical trials development? I'm Dr. Mariela-Vasileva, and I'm a breast surgeon from Bulgaria. And I'm very happy to have today with me first Maria Popovic, who is our communication coordinator, then Carmela Caballero, who is the chair of the Young Group of European Society of Surgical Oncology, and Dr. Ruth Blanco Colino, who is a member of the transversal group with me of the Education and Training Committee. I would like first to say that this webinar is very, very important to us, and it's very much needed, both for surgeons, young surgeons especially, and for patients. And I would like to give here the words to Dr. Caballero to tell us more about why it's needed for all members of ASAC and not only, of course.
Hello, everyone. I am Carmela Caballero. As Mariela mentioned, I am representing here the ESSO Young Surgeons Alumni Club. Maybe if you will allow me, I will just quickly share a few slides about ASAC. Very, very fast. Okay, so as most of our... is it fine? Can you see my screen? Well, okay.
Yes.
Okay. So as we are expecting that majority of the audience is for our young surgeons all over the world, we wanted to give a brief introduction about what ASAC is doing. As you know, ASAC is the young surgeons arm of ESSO, and the main mission and vision of ESSO is to cure cancer together. The Young Surgeons Group, we are composed of several members, but we have the steering committee, which is the core group. We have the Research Academy, which is the platform for learning and collaborative research for young surgeons. And we have the National Representatives Group, which is the Young Ambassadors of ESSO. And now we have 44 representatives from Europe and beyond. So the main, as the young group of ESSO, this platform allows us to connect with each other, to collaborate for surgical oncology improvement and for research, and to contribute to the overall mission of ESSO, which is to cure cancer together. We have many resources that are available for young surgeons who are part of ESSO and part of ASAC. And we would really want to take this opportunity to invite everyone to the upcoming annual Congress of ESSO on October 2 to 4 here in Belgium, in Antwerp. And a very special invitation to young surgeons all over the world to submit surgical trial proposals to the ESSO 43 Dragons Den. So these are, we are welcoming projects. There are trial proposals, not yet recruiting, but in the very, very advanced stage of development already. We have 3 categories of potential proposals that we can evaluate: randomized clinical trials, non-randomized clinical trials, and trials that are specifically set up for low and middle income countries. The top 3 will be given a 5-minute pitch during the ESSO Congress. There will be one winner, and the winner will receive a cash gift from the main proponent and supporter of this program, along with ASAC, which is the Anti-Cancer Fund of Belgium. So we are really encouraging everyone to participate. And with this background, this is the reason why we would like to do this webinar to encourage surgical research, considering the patient perspective as we develop surgical research. So thank you, Mariela. You can now. Thank you for that, Mariela.
Thank you very much. Maybe you said it, but just to remind that the deadline for abstract submission is 15th of May. So there is still time that you prepare your work for our conference. I would like to tell everybody that they can ask their questions in the Q&A section or in the chat, and we'll be happy to respond them if there are very burning questions at the end of the lectures, but preferably we'll have a discussion at the end. So we have three wonderful speakers this evening, and I would like to give the chance to Ruth to introduce the first of them, please.
So, good afternoon, everybody. Our first speaker, I had the pleasure to introduce Tanja Spanic, who is a professional patient advocate, and she's the current president of the Europa Dona Slovenia, and she's also the past president for the Europa Dona, that it's the European Breast Cancer Coalition, and she has been an active breast cancer advocate nationally and internationally, and has also role as a faculty member for BCI and ABCC, and is also taking part of the steering committee of a couple of clinical trials, Olympia and the positive trial, that it's part of the ESSO. She's also a patient advocate working group in the policy making proposal in Slovenia, and she has been working really hard in terms of research and getting both patients in breast cancer. And I will introduce also Lady Meheus, that it's our second speaker, and it's very good to come with her as well today. She is the managing director of the Anti-Cancer Fund, that it's a Belgian private research funding that started 15 years ago. She has also PhD by training, and she got diagnosed with breast cancer in 2018, and is also a member of the patient partnership initiative, that is the breast international group. And I think that Tanja Spanic is also part of this group. So I will let Mariela introduce our last speaker as well for today.
Thank you. So we have our gentleman at last. This is Professor Mark Lawler. He's Associate Pro-Vice Chancellor and Professor of Digital Health in Faculty of Medicine, Health and Life Sciences, and Chair in Translational Cancer Genomics, Patrick Johnson Center for Cancer Research, Queen University, Belfast. And many other things, actually. So I will not try to tell them all. And thank you very much. We are very much waiting for your presentation. Just to invite everybody to introduce again in the chat and to tell where they come from, because I really hope this will be a nice discussion at the end. So thank you, everyone, again. And we give the floor first to Tanja.
Thank you, everybody. First, thank you, ESSO, for the invitation. I'm going to share my screen. I hope you see it now. So my presentation is about the patient perspective and what are the current hot topics where surgeons and patient advocates can collaborate to develop, let's say, more patient-centric clinical trials. But first, just a few words about Europa Dona, the European Breast Cancer Coalition, which I was the president in the past 4 years. We are the pan-European umbrella organization for breast cancer, and we have 47 member countries. As you can see, we go way beyond the borders of the European Union, which we think is very important, especially regarding our main, or let's say our main goal, or our main purpose, to ensure all European people to have access to accurate information, quality screening, diagnosis, and treatment in breast cancer. And what do we do as the coalition? We do mostly advocacy. We share information with our our national groups. We do education trainings for them. We educate between our members, and we do also collaborate with other expert organizations, like also as you mentioned earlier in my introduction, and we strongly support research, which will be one of the topics of today's talk. But just briefly to enlighten what the life looks like of a common person that got the breast cancer diagnosis. You suddenly end up in a totally new world with unknown words. We can say that we have to learn a new language, and there's a lot of anxiety, uncertainty, what we are going to experience. So I will now focus maybe more on the European EU member countries. We get the treatments within the breast units where we are in the multidisciplinary teams, and these teams are definitely very, very strong teams of healthcare professionals, including surgeons, medical oncologists, radiation therapists, genetic counselors, dietitians, psychologists, and this is very important that we get it from the very beginning. But still, in many cases, the treatment starts with the surgery first, and all other treatments are followed. That's why it's very important that we understand the types of surgeries and what we will go through, what are the options for the surgery, and also to take into account patient's view, not just the expectations of the end treatment and expectations from the science and from the doctors, that patient's view can sometimes really differ from the doctor's view. We also tend to support our community with lay language material, which we find it's very important. So this is the point what I would like to appeal to all of you, how important it is to explain everything in a lay language, and also with involvement of the patient representatives early in your development. So surgeries in the past years became really personalized, let's say tailored also as other parts of the treatment in breast cancer, and not to miss out the reconstructive surgery, which is very important, not just for the treatment outcomes, but of course also with the self-confidence outcomes and personal appearance of the patient, of course also involving the molecular biology of the tumor itself and genetics that I may also mentioned earlier. And don't forget about pregnancy and fertility issue, especially in younger patients, even if we are discussing today the surgery. So it is the possible pregnancy after treatment of breast cancer. Earlier, you mentioned in my introduction positive trial, and of course, breastfeeding after the treatment is very important. So side effects of the surgeries are very important for us. Rehabilitation, recovery concerns. Here as side effects, it's not just meant the physical disabilities, but also the effects of lymphedema and everything that comes with this recovering. In our previous earlier discussion before we started, it was tackled that we are not so much involved in maybe in some part of the research, but I hope that I will convince you right the opposite. As Europadona, the European Breast Cancer Coalition, we are quite well involved and invited to different groups, and I will address just a few of them. In a collaboration with Oncoplastic Breast Consortium, we developed the Lucerne Toolbox, and we were part of this process from the very beginning. We were involved, many of us, more than 12 patients, I think 15 patient advocates, from the very beginning in the Delphi questions and all the way till the end. One of the very important topics in the past few years regarding the surgery was the manifesto at the EBCC 13 conference almost 2 years ago, where we addressed the contralateral and the importance of balancing pros and cons for contralateral prophylactic mastectomies in breast cancer. And the Europadona was a very important partner in this because we ran a survey among our member countries, and more than 500 women across Europe reply and gave their concern. So one of the very important topic was that we don't treat anxiety with surgery, that we have other methods to treat anxiety in patients, and that there is no way back after a radical surgery like bilateral mastectomy is. And We also very good collaborate with Eurobreast, especially in past few years in development in their new trials and questionnaires, especially in quality of life during the trials and also in clinical practice. We already collaborated with ESSO at some political events, policy making events, and also in other training events. And also we very good collaborate with BRESO. We were one of the supporting founding members in this initiative. We also collaborate with other expert groups, with few European projects. Maybe one of the most known is Cinderella project, where we are also part of the steering committee. One of this, let's say, European Society for Breast Cancer, SOMA, is also one of our partners, where we always also bring the patient perspective to it. European School of Oncology, the project Greta that is run among the different stakeholders, Central and Eastern European Breast Cancer Surgical Consortium, UEMS, EBS. You probably know this better than I do, what it all means. But just before I conclude, is what is actually the aim of all of our work and this collaboration? It's to create more patient-centered environment, not just the treatment and the clinical trials, but the whole environment for breast cancer. And of course, the consequence of this is patient-centered trials. That means that the trials are actually answering the questions that are relevant for patients and for outcomes of the treatment, and not just maybe addressing some part of the question, but the whole process, to ask and to fulfill the unmet needs of the breast cancer patient society, and of course understanding individuals within this community. And last but not least, the important thing is to treat the tumor. Don't treat just the tumor, but you have to treat the whole person. So, and if I just conclude with the answer to that was my question, my title is, what is the current hot topic? I think that the most important hot topic is that for every person, for every affected patient, we find the most optimal surgery for that individual. But of course, we need trials to find the outcomes of the treatment. Thank you.
Tanya, thank you very much. It was very interesting, and I also see in the chat while people are introducing themselves that actually there are a lot of people coming out of Europe, and I just want to ask, maybe during the next presentation, they may say if in their country there is how to say strong patient advocacy group, and because you have it already, you're much further, but probably many people don't have it like an organization. So it will be interesting to hear this. And meanwhile, I'm very happy to give the floor to our next speaker. So Lily, the floor is yours.
Yes, thank you. Do you all hear me?
Yes.
So thank you for the invitation, and there you go. Uh-oh, sorry, my slides are not moving. Okay. Yeah. Sorry, I will start again.
Yeah.
Maybe that's best. I guess. Let's see if. Okay, now it works. Sorry. So yes, as was said, I have nothing to disclose, but besides my own diagnosis, which you can read here. So I was successfully treated by surgery, chemotherapy, and radiotherapy. And then my background, so I'm a PhD by training, and I'm responsible for the Anti-Cancer Fund. So we are a non-profit organization based in Belgium. And we are supporting patients in different ways. by giving them free personalized information regarding their treatments, and also by supporting clinical research where there is no commercial drive. So as was just mentioned, surgical trials mostly are lacking commercial sponsors. So that's why they are in our scope. But besides that, we also support drug repurposing trials, combinations of repurposed drugs and radiotherapy, but really broadly, those trials where there is a clear unmet need for patients and where there is no business model or commercial drive. Those are the criteria for the research we support. And then in the longer run, we also perform policy work. We're based in Brussels, so we're close to the center of Europe. And there our aim is that, the ecosystem should be more patient-centered, because today we think it's still very much driven by the commercial players, and we would like to see a complement. There's nothing against that, but we would like to see a complementary path so that treatments that are not supported by a business model also get properly developed and get implemented into the system. And proper development means, of course, clinical trials in most cases. So since you are all very young surgeons, I would like to start with a lesson from history, because for breast cancer in the 60s and the 70s, surgeons were going towards more and more radical mastectomy, and really leading, taking away the pectoralis muscles, and by that women were mostly disfigured, and that went further and further until certain Dr. Fisher came with an hypothesis that maybe there is the molecular biology behind breast cancer is not as it was as the hypothesis, that you could just cut it away further and further, but that it's more systemic disease. And so, but of course, he was the odd man out and a maverick, and that was not much appreciated by his colleagues. So his idea was to set up a trial to prove that mastectomy compared to lumpectomy combined with radiotherapy and then later adjuvant chemo, but he got a lot of opposition. And thanks to the women and patient advocacy groups, avant la lettre almost, the women started even demonstrating in the US and asking the government to support this type of research. Finally, after a lot of struggle, they could set up the trials. And we all know the result, the rest is history. But you can read all of this in the book that is here, The Emperor of All Diseases by Mukherjee. But this is really important, I think, to demonstrate if you don't do the trials, what can happen. Millions of women have been disfigured by not doing the trial. And it's really thanks, of course, to Dr. Fisher, who was thinking out of the box, but also, and especially to the patient advocacy groups, that today I'm still here with my breasts. So that's for the history part, I would say. Then, so my main message is that also surgical innovation requires really evaluation. And today we are used to that for all drugs, but in surgical oncology, I think it's much more difficult to get proper evaluation. Although there are guidelines, I think the ideal guidelines from the International Conference of Harmonization on Good Clinical Practice. There are guidelines, but yeah, it's not easy to implement, and especially the funding, I think, is really a major issue for the surgical research. And that's why we think the system has to be adapted, the whole funding system also. So if you ask me what is important for the patient and can the patient contribute to the design of a better trial, if you think of a trial, for the most important question here is there equipoise? Because if you want to motivate a patient to participate in a trial, it has to be clear that you don't know the answer up front. And of course, in some cases, and that's a case I'm just giving here an example where you see that if upfront there are already a lot of data out there demonstrating that the intervention is really beneficial, then I think it's a difficult ethical question to do a randomized trial. But here I'm absolutely not the expert of designing trials, but the message I would like to bring is that if you start thinking of a trial and you have a research question, this is the first thing that you have to ask your colleagues, or that you have to think about and maybe involve patients. Can you justify randomization? We all believe that randomization is a very valuable system to raise evidence, but the bottom line is you need equipoise before you can go make a choice for randomization. Because for a patient, if you are an ovarian cancer patient and then you know that the major, and it's really, you're talking about your life, then you don't want to go in a randomized trial if there are already solid data out there that give some answers. So, but yeah, it's an ethical question, I know, and it's the origin of a lot of debate, but to have the good trial and to be able to recruit sufficient patients, I think you really have to think of this question first. So, and today I must say there are more and more thinking of different designs of clinical trials with synthetic controls or other solutions. As I said, I'm certainly not the expert, but those are the first things you should think of, the high-level design of your trial. So then the question, another example I would like to give here about trials is that they don't need to be very fancy and high-tech to come with something that is valuable for patients. I think this is an example of a clinical trial that was performed in India, in Mumbai, and I think with very interesting results. When you look at those curves, of course, this is something that needs to be repeated. In the, let's say, the Western world, in Europe, and there again, we face the problem that this type of trials are maybe not sexy enough for young surgeons who have a preference for very high-tech, let's say, newer things. But if you take it from the patient's view, something that is simple and that can really improve your quality of life and your lead to longer survival is again a research question coming from patients. And as Tanya just said, I think today, what we see with patient involvement is that patients will come at the moment that the trial is designed and then can give their input. But in the ideal world, I think we should also deal with research questions really originating from patients who want to have this type of simple results that look very attractive to them. But then the question is, why can this not be trialed in the Western world? And yeah, this is a question I have to ask to all of you. Like, would you be interested in that type of trials? How can we make sure that those things that look valuable and that have been presented at ESMO, there's a GCO paper. So I think it's already some decent quality, and I agree when we talk to people in the Western world, everybody says it has to be repeated in the Western world, and I certainly can agree with that. But how to get that organized and how to motivate surgeons to really step into that type of research that is of importance for patients. Then I have another question for you. Sorry to be so pragmatic. That's actually a question I was confronted with my own diagnosis. So what we see in breast cancer is that in my case, depending on the clinic where you will be operated, you will have either a one-step operation or a two-step operation. One step is going where the decision to go for axillary lymph node dissection is taken immediately by the pathologist, or where and then you have, it happens while you are on the operation table. But finally I chose for the university hospital, where they explained to me the two-step operation, where they take the lymph node, the sentinel lymph node, and then they follow the NCCN guidelines. They do all the staining procedure, and then according to the NCCN guidelines, the presence of micrometastasis, yes or no, etc., then you have a more, what I would call, a shared decision making, where afterwards you can the lymph nodes could still be removed, but then of course you need a second operation, but at least there is a clear process, a clear procedure. In most cases, patients are not aware of the two possibilities. It's just the hospital that determines whether you will have a one-step operation or depending on what is offered to you. You're rarely offered a choice, I would say, with the explanation. And there again, because lymphedema is, I think, a serious side effect that goes with the lymph node dissection. So I think here again, the importance of informing patients, of bringing them, let's say, to a level that they can, that you talk to them and explain the things clearly, would be a step in the right direction. But of course, I know there's a lot of practicalities that go with that, and I'm talking about the ideal world. But on all this, I would be happy to hear your thoughts and your ideas. And as I said, for me today, it's still an open question, and I don't know if somebody in the room has the answer. What, in the long run, are there data available to see if one procedure or the other gives better results? Honestly, personally, I don't know. So it's an open question for the speakers and the audience. So I would like to conclude here, and yes, better research, I think that means issues, you deal with issues that really matter to patients. That's, if you ask me the question, that is what I would call better research. And as I said, research questions from patients should be taken into consideration. Of course, there's a lot of other questions to answer. I know there are scientific questions, there's a lot of questions to answer, but at least in some cases, the research questions from the patient should be taken into consideration. And what I would call impactful research is results that you can then directly implement in the day-to-day cancer care. So yeah, I think that's where I want to end, is that it's very important that to involve patients in your research, because it will improve the feasibility, the trust, and also in the end lead to better recruitment of your patients if you have understandable, informed consent, and if you have your patient on board. Thank you, and I would like to stop here.
So, dear Lily, thank you very much. It was very interesting. I think I have a question, but I will.
Yeah, I hope you have, and I hope.
Yes, but let's first continue with our last speaker. This is Professor Lawler, and then we'll have time for discussion. So, Professor, the floor is yours.
Thank you very much. Can you see that okay?
Yes.
Okay. So first of all, I'd like to thank the organizers for inviting me to speak. I've worked with ESSO a lot in the past, and it's great to be working with you again. The second thing I'd like to say, I'm really impressed by the geographical distribution of the participants in the webinar today. And I'd like to particularly say thank you to our colleagues from Ukraine who have joined us from Kiev. We continue to stand with you in your struggle, and we continue to support you as best we can. And so thank you very much for joining us here today. What I want to do really is look at some aspects of why we do research and what sort of research we should be doing. And it'll sort of echo nicely in relation to what Lydia said. We have to be doing research that is relevant to patients. I'm going to take you through a couple of stories and also a little bit of history in relation to my engagement with patient advocacy over the last decade. So my sort of involvement in patient advocacy stretches back approximately 12 years ago, where we looked at what were the problems that cancer patients were facing in Europe. A number of us came together and said, what are the problems and how do we address those problems? And that led us to perform what was at the time the most comprehensive evaluation of cancer inequalities in Europe. And unfortunately, we found very significant differences between countries and sometimes within countries. But what it did was it allowed us to work very closely with patients and co-create with patients a charter, which we call the European Cancer Patient Bill of Rights. And that charter was really designed to challenge the inequalities that cancer patients were facing, unfortunately, every single day of their lives. We hoped that it would be a catalyst for change and also an empowerment tool for cancer patients. We were very privileged to accept the 2018 European Health Award for this work, and that was specifically given, or is specifically given, to recognize health initiatives that have or have had a European-wide impact. That has led then to us developing what we call a European Code of Cancer Practice, and this was developed, co-created with patients, equal number of patients and health professionals involved in the development of this. And it essentially identified 10 rights that the patient should expect to receive from their health system. So in terms of access, in terms of gaining information, in terms of the expertise and the outcomes that you should expect no matter where you're diagnosed or treated, and that you should be treated in a multidisciplinary care setting. Again, going back to what Lydia said, that there should be shared decision-making between the patient and the healthcare professional, that research and innovation should be embedded into what we deliver, but also that we need to think very much importantly in relation to quality of life, in relation to integrative, supportive and palliative care, survivorship, but also rehabilitation and reintegration, which a lot of people don't necessarily think about in relation to how we drive better care and really have a code of cancer practice that's patient-centered. And the second thing I want to highlight is the importance of data. So as well as having very much a patient-centric view, we need to have a data-enabled view. And one of the things that we've been very much pushing over the last 5 to 10 years has been really to try and create an ecosystem that can drive research and innovation, but that is very much patient-centered. And that should go across the whole platform and the whole pathway in relation to cancer. So in relation to prevention and early diagnosis, but also data-enhanced discovery to develop new approaches. And they are not just developing personalized drugs. I'm going to talk about this in a lot of detail. Surgery and radiotherapy cure more patients than personalized medicine. And we still need to remember that and act on that and look at ways in which we can support personalized surgery and personalized radiotherapy. But the other thing that, again, really important, both nurturing and empowering patient recovery and rehabilitation, and also looking at ways in which we can interact with industry, both as patients and as healthcare professionals, so we get the best for the patient. We've done this in the United Kingdom, where we bring together all those different data sets into something that is called DataCam, which is the UK's Health Data Research Hub for Cancer, which I'm privileged to be the scientific director of. And one of the things that we've very much regarded as a principle is to ensure fair value. And that fair value must be for the patient first, for the health system second, for the researcher third, and then for the industry fourth. So if everybody is getting fair value, then that's how things work. If people are not receiving fair value and it's very much skewed towards industry or academia, then that is not going to deliver for patients. And it's something that principle that we have put in place for everything that we do, all the interactions that we have. The other thing that's really important, and this was from the very start, so in order to set up DataCam, we had to apply for a grant from a particular competitive granting body, and we involved patients at the very start. So they were involved with us in the writing of that grant, in the construction of different parts of the grant, and also in the when we were actually defending the grant before the research committee. We integrate patients at all levels of our decision-making within DataCam. They're involved in both patient and public-led research ideas and projects. We very much have the principle of co-creation. Patients are on our management group, on our steering group, on our project groups. And they have equal and sometimes more representation than other stakeholders within our governance structure. And the other thing that's really important is patients are involved in all our discussions with research partners, and be they academic partners or commercial partners. And that's really important, that the patient is in the room for those conversations. And one of the things we found is that industry have actually come back to us and said, actually, that delivers better quality research, better ideas, thought out more properly, integrated so that it actually respects the views of patients, but also the challenges that patients have. And the other thing that we've been looking at, which is not easy to do, is to look to make sure that our patient advocacy also includes underserved and minority communities, because our voices are often unheard. So I just give you two quotes from our patient advocates. This is Jackie, the picture there. Jackie is a breast cancer survivor who I work with very closely. And you can see there, patients want their data to be used to improve care. In fact, they're often surprised that it's not used. And that's a fairly common reaction that we get from our patient advocacy groups. But the second one is the one that I really like. And this is from Pete Wheatstone, who up until recently was chair of our patient advocacy group. And he said, as patients, we not only are empowered, but we feel empowered. And that makes me proud, because it makes me feel that we're doing a good job and we're actually doing this as a co-creation between patients and healthcare professionals and researchers. For me, COVID-19 was a personal experience. My uncle was diagnosed and unfortunately died of a COVID-related illness right at the start of the pandemic. And one of my colleagues on the left-hand side there, Edward Vidoliak, who's an oncologist in Croatia, while he was reaching out to me to sympathize with me on my loss, he also said something that really scared me. He said that in Croatia, people are starting to fear a COVID-19 diagnosis more than a cancer diagnosis. With my colleague, Richard Sullivan, we sort of thought about that and said, Is that true? Have we seen evidence of that? We've heard some anecdotal things, but there was no real evidence. So with colleagues in University College London, we put together a very simple, straightforward research project. Research doesn't have to be difficult and complicated. You can do very simple things. So rather than looking at 50 parameters or 100 parameters, we just looked at 2. We looked to see, by taking real-time data or near real-time data from hospital trusts right across the United Kingdom, what was the impact in relation to people who presented at their doctor with a suspicion of cancer, so had some symptoms that might be cancer. And what we found was that 7 out of 10 of people who had a suspicion of cancer were either not going to their doctor or were not getting referred on to specialist services. That was a really scary number. Similarly, not quite as bad, but still pretty bad in the context of cancer patients, we saw that 4 out of 10 were not getting access to their chemotherapy at the appropriate time. And so we drew the attention of government, of academia, the public, etc., to really the disastrous impact of COVID on cancer services. This is just showing you what was the impact in relation to surgical procedures, here endoscopy procedures. You can see there the change between April 2019, that's a 92% drop. And could lead to significant numbers of deaths, thousands of deaths, because we've delayed over 500,000 endoscopy procedures. So we have a real problem here. And we also looked at it at European level. So this was as part of the European Cancer Organization, and a special network that was set up by the European Cancer Organization that I'm privileged to co-chair with my colleague from the Netherlands, who's looking at the COVID vaccination effort. But look at those numbers, really scary. 100 million cancer screening tests not performed. 1 million cancer patients may have been undiagnosed. Look at this in relation to surgery. 1 in 2 cancer patients not receiving surgical or chemotherapy treatment on time. And also you can see there the impact on the cancer workforce. 4 out of 10 feeling burned out, 3 out of 10 showing signs of clinical depression. So these are real challenges that this data throws up for us. And it means that we really need to think creatively and innovatively in terms of how we get back, how we reverse that backlog, how we actually address issues that patients have probably been diagnosed at a later stage, and the impact that that can have on their treatment, particularly surgical treatment. And the other thing that we realized was that we needed to think about what are we doing in relation to cancer research in Europe. There's a lot of fine words spoken about cancer research and the EU Cancer Mission, but what we decided to be quite tough and actually look to see what are we doing as of today and how might we do better in the future. And this was a Lancet Oncology commission. We brought together 50 experts, including patient advocacy experts from right across Europe, to really look at collecting intelligence to inform a series of recommendations. And I often feel that we place too much emphasis on opinion and not enough on actual evidence, and even expert opinion. We really need evidence in order to make changes, make new implementation of cancer policies, look at pragmatic solutions in relation to what type of research we should be doing. As you said there, making research much more relevant to the patient. We deliberately called it the European Ground Shot Commission, because we felt it wasn't something in terms of shooting for the moon like the American moonshot. We wanted to ground it in reality and address the situations that we're seeing in relation to research. And the other thing is we put it in the context of a vision, a 70-35 vision. So that's 70% long-term survival by 2035 for the 20 million people living in Europe with cancer. One of the things that came out of this study, as I said, is the most comprehensive study of cancer research in Europe. It unequivocally showed that patients who are treated in research active hospitals or centres have better outcomes than those who are not. So research is not a luxury, it's an integral and essential part of modern European cancer care. Just going to show you a few little snippets from it. I don't want to dwell too long on these, but this is just showing you the difference, the cancer divide between Western Europe and Eastern Europe. You can see there a doubling of cancer research in the period that we looked at it in Western Europe, but stagnation and little progress in Eastern Europe. And our recommendation really was that no matter where you live, you should benefit equally from the advances that happen in cancer research. The other thing is the cancer research portfolio, and this very much relates to surgical research. We feel that there's too much discovery, too much emphasis placed on a narrow focus on discovery science and biopharmaceutical research. We need to be much more comprehensive, looking at different diseases, different cancer types, but also different modalities of therapy, and including surgery and that. And the other thing is we need to look at how do we implement. We're very good at discovering things. We're not so good at implementing. And so we also said we need to really look at implementation science, health policy, health systems research. This is just an example in relation to what we actually spend our money on and what we take our research activity on in relation to cancer incidence and burden. And I just focus on one cancer, lung cancer. It's 21% of the disease burden in Europe, and yet it only is expended 4% of the research activity and 4% of the research spend. So that doesn't really make sense. So we really need to look at reorientating how we actually do research and how we fund and prioritize different diseases. But what I really want to concentrate on is two things. One, comprehensive cancer centers make sense. The data that we've shown really shows that. And the other is really important is that we need to focus less on cancer breakthroughs and much more on cancer follow-throughs so that we're actually delivering for our patients. And the other thing is what we've found was surgery and pathology and also radiotherapy all have much lower focus in relation to research. And that's simply not acceptable. 50% of patients, as you know, have an evidence-based indication for either radiotherapy and or surgery. And also, if we want to have precision medicine, if we don't have pathology significantly, then we're not going to have personalized or precision medicine. So really emphasizing that we're significantly underinvesting, and the European EU Cancer Mission needs to take cognizance of that and actually look at reorientating so that surgical research, for example, obviously particularly relevant to this audience, is much more prioritized. And the other thing is we need to focus much more on the survivorship research, also under-researched, underfunded. We've come out with a European Survivorship Research and Innovation Plan. It's obviously particularly relevant in the context of patients who have received surgical interventions. And we really feel that we should come out with, for example, a European Cancer Survivorships Day to really put the focus of attention on the 20 million Europeans who are living beyond a cancer diagnosis. I started with talking about data in the context of the European Cancer Patient Bill of Rights. I'm ending also with data as well. And this is a new initiative that we brought out in the last year or so in the European Cancer Organization called the European Cancer Pulse, where we're tracking inequalities in Europe in relation to cancer diagnosis and cancer care. You can see we want to focus on all aspects of the cancer policy and cancer pathways, all areas of social inequalities, all type of available data sources. And I'm making a plea because at the moment, the amount of surgical data that we have is relatively limited. So we'd really be interested in working with you to get more surgical data, to get some of your younger researchers particularly involved, perhaps in working with us in doing surgical research projects that focus on data. So certainly you'll be very happy to look at ways in which we can work together going forward. And I've just put that paper that we published back in the Lancet Oncology that just tells you a little bit more about that project. So really just to end, and I loved the trust in God and everybody else needs to give evidence. I'm obviously of the same principle because really we need to look at not just using opinion to make decisions, but actually using hard evidence and really looking at how we unlock the power of data to really improve our health and well-being. So thank you very much. Very happy to take any questions or comments. And again, thank you for the opportunity to be on this webinar today. It's a real privilege.
Mariela, I just, if you would allow me, I would just really want to take a little bit from what has been said by all our speakers and to emphasize, when we speak about personalized care, I guess there's nothing that will be more personalized than a surgical treatment. And as a lot of the audience that we have today, we have patient advocates actually in the audience, and I'm very, very happy to hear that. But majority of our attendees are surgeons. The talks and the messages that we have heard today is really, it's an action, it's really a call to action for young surgeons, for surgeons all over the world, to really think about the best possible research questions, because so much is at stake when we speak about cancer surgery. And we are there at the forefront of the treatment and the long-term care. So it is so important that the surgeons think about the right questions to ask and the right way to address these questions. So I would be so happy to hear the questions and the discussions that I'm sure will come up. So I don't know, Mariela, would you want to ask your burning questions?
Yeah, so I was thinking a lot while listening. You're quite the same as you said, that in our audience they are both surgeons, young, but it seems like there are lots of patient advocates. And I wanted to ask first Tanya and Lydie, when they decided to become a patient advocate, do they believe that with this they can really change something in their practice, like really when you become a patient advocate? Because I think patients, they're everywhere. Lots of people are patients, but not everyone became advocates. So how it happened?
It's actually hard to answer in a very short, but I'll try. Even for us who are involved, it's very hard to find new patient advocates, because this is, I always say, a very boring and nerdy job you have to do. So I probably became patient advocate because I was diagnosed with breast cancer almost 16 years ago. I was 26 at that time. I was a young researcher, a PhD candidate in the field of molecular and behavioral neuroscience. So brain was my topic, and actually my team was joking if I will switch from brain to breast. Well, I didn't. I finished my PhD and I finished a postdoc, and then I left science because I felt that I can do much more with all knowledge and my personal experience in the field of oncology than in neuroscience. And I think that things are changing a lot in the past, let's say, 10 years regarding all the setting of the clinical trials, and even medicine agencies like FDA and EMA also taking already into account patient-reported outcomes as secondary endpoints, and bringing also patient representatives in their own boards and committees. And this is another challenge. So we have to be trained. We have to be so-called patient experts to understand all of this. And that's why we also build so much this big bridge between scientific language and lay language, because it's really important. You cannot participate in the shared decision making without understanding. And at the beginning, even if you have a medical background, you don't understand everything because you're not from that field, but you tend to learn pretty quickly. You need maybe just a few days or a week to study it a little bit into detail. But to make a really relevant shared decision with your doctors or with your team, you have to be really very well informed and empowered. And that's the role of patient organizations, to provide this to newly diagnosed people very quickly and in the understandable language. Because from our experience, patients later say that with the current status, let's say a year or two after the diagnosis, they got so much knowledge and understanding of the disease that maybe they would make a different decision if they would have this amount of knowledge and resources at the beginning. But that's almost impossible. That's why this communication, patient, doctor, talking, breast cancer is not usually, very rarely it is an urgent matter, but you have day to a week or 10 days to discuss, to rethink, to discuss with your patient, as Lydie said, 1-step, 2-step surgery. You don't know nothing about that at that time. So I think that these are very important things for you as a young doctors and for your community to also understand. That's your daily job. You deal with that every day, and it becomes very natural to you. But for a patient that you see, it's not. It's a new world every single time you come there.
Yes, it's up to me. Well, it's kind of a difficult question for me because actually I didn't I'm not really a typical patient advocate, of course. As I said, since 15 years, I'm responsible for the Anti-Cancer Fund, which is a research foundation. But then, yeah, I got the diagnosis and I became an expert, so to say. And afterwards, then I joined PPI. And so, like, I'm a patient advocate in my free time. But yeah, in my job as responsible for the organization, of course, I'm very much aware now. It's really a benefit to, honestly, that I got to that I was diagnosed myself. If to be honest, because then you realize you get all the questions from the patients through our information service, and that gives us the boots on the ground, so that for our clinical research we try to really focus on research questions that are important for patients. But yeah, I think for me it's just not a choice to become a patient advocate. It just happened to me.
I guess I wanted to pick up on what Tanya said. Indeed, there are so many patients. We have so many patients with cancer, unfortunately. But again, I mean, not all of them are able to become patient advocates, or not all of them can be expected to, be involved in research. And indeed, training is needed, and the commitment and the willingness to work with the scientific community to develop these questions it's really so important. So I think it's so important for the surgeons or for the researchers to be sensitive to the patients who are actually more interested to contribute and to help out in this aspect. And maybe once we identify some patients who are actually wanting to go beyond their personal experiences and really contribute to a bigger audience, there's possibility to actually work together and work with the scientists and with the researchers to actually to allow them to be involved in a bigger kind of work, which is patient advocacy and research development for more people beyond beyond the individual. So, but I think the surgeons, as they are usually the first in contact with the patients, they're usually more aware what kind of patient they are dealing with. And if they are able to identify such a patient, then I think we should really try to work with them and try to understand how the surgeon and the patient can work together.
And I would like to continue on Carmela's thoughts, because at the same time, so as young surgeons, we need to identify patients who maybe walk the extra mile to become an advocates. And then I was thinking, what if you're a patient in a country where there is no organized advocacy groups, and you want to make the extra mile, but you don't have anybody else around you, then what would you recommend? What these people, we have people today from Nigeria, from Kenya, from India, I think from Pakistan, if they want to go the extra mile, what they should do first, maybe?
Well, the thing is that today I really believe that this environment changed a lot in the past decade, and we have so many also resources that are available for people all around the world for basic trainings in advocacy and understanding science. Maybe it's a good step once a doctor or a surgeon knows a patient who is a little bit of interested in this, can share or can connect with someone that they know, either for international community. Maybe it's easier. There's a lot of open source training or teaching platforms, at least in Europe and North America. But I also know groups from Africa, Southern Africa, that are very active. So maybe through all existing communities, they can also build their own ones. It's really hard to have one person then motivated and keeping motivating. Sometimes, at least historically also in Europe, in breast cancer, it was mostly that nurses and doctors from breast units started encouraging patients to become the groups, and then they became like peer-to-peer support groups, and slowly they grew. It's hard to start just with advocacy because it's really a lot of work, but it usually starts other way around. They support each other, patient to patient. But yeah, as I mentioned, there are so many resources, and also with, let's say, OPATI in Europe, and also BIG now with PPI is doing a great job and providing several trainings, and other patient groups like We Can also are building the programs, and everything is available and open source, explaining the science and the research. Maybe it's not so cancer specific or breast cancer specific, but you can find a lot of resources. Even in Australia, they are very active in this, and they have a lot of available resources. Even in Asia, there are a lot of groups. Even in Pakistan, we know groups, in Malaysia, in India. So it is possible to connect with people. South America also. So yeah. Thank you, Carmela, for sharing the links. Yeah.
Perhaps it will be nice if a person who wants to become a patient advocate finds a surgeon who wants to start a trial, and they both communicate on this. And I think I know the answer, but I will ask one of the questions from Ruth, actually, that she prepared yesterday. At what point of clinical trial development should be the advocate involved?
The very start.
Absolutely.
Brainstorming, as Mark said from the very start.
Yeah, very start.
Yeah.
Then
Absolutely.
you will have the first test. This is really patient relevant question.
Also,
That's the key thing.
Usually we get involved very late when the trial is already set and already approved by ethical committees, and you know how hard it is to go back. And they see later, oh, maybe this could be changed, but it's so complicated. Even more if the trial is multicentric or in more countries, it's a nightmare to change it. So usually we get involved very late.
Rosie, you wanted to say something, yeah?
Yeah, I would like to ask them, in terms of from the ESSO society, how do you think that we could better help patients advocacy, and how we can be like a platform to help reach joint surgeons that want to develop research, but at the same time to be like a platform to contact patients that would like to take part in the design of their studies at the early beginning? If you have any ideas or any proposals.
Well, as mentioned a while ago, so now we can, I think the program of ESSO 43 is out, and they're actually for this specific, for this year, upon the request of many attendees from last year, we have actually expanded our sessions that are bringing together surgeons and patient advocates, and to discuss a bit more how they can work together, and also how trial designs can be developed with keeping in mind the patient perspective. So we have actually dedicated sessions this time around to focus on this. And as mentioned, from the side of AZAC and with the help of Anti-Cancer Fund, what we are really trying to do is to encourage the surgeons to develop research proposals. First, we started this last year, develop research proposals, which Liddy mentioned a while ago, that are that can be generalizable to many settings around the world, in particular from in low and middle income country settings. So we are accepting trial ideas that can be done anywhere in the world. So this is one thing that we started to do. And now what we have also tried to do is try to incorporate the patient voice in this kind of development of surgical trial proposals. They can also surgeons can also submit their ideas through the AZAC Research Academy. And maybe I can also mention, as both Tanya and Lydia are working quite closely with the Breast International Group Patient Partnership Initiative. The answer to that question about when and how patients can be involved, it's really, as Mark also said, at the very, 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 very beginning, at the earliest time, when you think about the research question. In fact, one of the first things that you can do is talk to your patient and ask, what do you think about this? Because that will really help develop a better kind of research design when you immediately understand what the patient needs. So this is something so important. I don't know if Mark can say
very,
more
very
about
happy
this.
to comment on that as well, Carmela. Absolutely agree. And I think some of the organizations, the cancer organizations in Europe, were guilty in the past of having separate sections, saying, oh yeah, well, we're covering patient advocacy, but it's over there somewhere. And that's the wrong way to do it, because what was happening then was that the cancer patient advocates were simply talking to each other, and they already know each other. So there wasn't really much benefit from that, whereas it needs to be, both the patients and the surgeons need to be in the same room, not in different rooms. And that's why I'm delighted that you're doing the initiative that you have. It makes absolute sense. And that's the earlier the better. I mean, we've found, particularly the work we've done with Datacam, what we found is the industry have come back to us and said, actually, you've helped us to make our studies better because you've had patient involvement, and also you have made it clear what's practical. Because sometimes people might have great ideas about doing something, but it just doesn't work either in a particular region or country, or the difference between the States and Europe and that. And, explaining that to people, patients are the best at explaining that, because they know what's physically happening, what are the different practicalities that you have to deal with. And I think that's an important aspect, that, it's not just the science, it's actually, is this going to practically work? Is it going to work for patients? I always give the example of a study on teenagers where they were asking them to give blood samples at 8 o'clock in the morning. I don't know any teenager who's up at 8 o'clock in the morning. So, it's a trivial example, but you know what I mean. I'm just trying to deliberately sort of accentuate the thing. You need to be doing things that actually will work for patients, not something that is impossible to do in the real world.
That is, I think, so true. Also, sometimes we are very much guilty of thinking about study procedures in clinical trials that are too cumbersome for patients, and we don't, as the trialists, we don't realize it. For example, as much as we would like to understand quality of life, patient-reported outcomes, we've seen trials where they ask patients to answer 10 forms with 20 questions each. I mean, honestly, a patient who is undergoing treatment, how can you expect such a patient to answer 80 questions in one sitting? So this is something sometimes we forget, but once you have a patient on board, then you have a better view of what works for them, as you said. Maybe I want to check with you as well. As you mentioned a lot about initiatives that are using technology, AI, and I know Mariela has a really great initiative to utilize mobile apps to reach out to patients. Maybe I want to ask the audience or the panelists, does this kind of technology, does it really help to personalize the care, to personalize the treatment. What's your take on this? It's undoubtedly helping us to gather data, but do you think that it helps to, the personalized care? Does it contribute?
I think it has potential to do that. I think the thing we have to be careful about is that it doesn't widen the inequality gap. There's a danger if you rely totally on technology. Not everybody has the same access to technology or is able to use technology. So sometimes you're selecting out a population that is very comfortable with technology rather than a sort of a random sort of selection of the whole population, which is obviously what you prefer to do. I think obviously we've seen the whole impact of digital in the context of having to sort of respond post-COVID, and that has certainly worked. And I think we certainly are doing things that we probably wouldn't have done in the past, and they've worked very well. But I think there still is that need to have the patient health professional interaction as well. So I think there are certain things that work well. I stood up at the European Cancer Organization 2 years ago in the plenary session, and I said one of the challenges that we faced when we moved from virtual to back to face was a lot of the people we'd never met before, we couldn't work out what height they were in terms of, because they looked like some people we thought were smaller, were bigger, etc. So you can't judge everything from what you see on the screen, particularly sort of gait, sort of sometimes your behavioral aspects. So I think it's finding that balance. It's a little bit like AI and pathology. AI is good for some aspects of pathology, but hasn't been proven prospectively in other aspects. But it might be something that, for example, does I'll talk about it as the routine work that can be done straightforwardly and then release then the pathologist to look at more complex cases and have more time to look at those complex cases. And I think you could use the same analogy in surgery and radiotherapy, etc.
I was wondering to continue this collecting data, because yes, I know in Europe collecting data is not easy, but possible. But what I don't know. I know that not all European countries have a cancer registry. Even in Greece, they are now opening it. In Serbia, they are now opening it. And in Bulgaria, unfortunately, we closed it. So I don't know what will happen and how we'll continue with this. But yes, how do you see collecting data from even out of European countries?
I think you raised a very important point. I mean, I'm a big believer in cancer registries. I chair the International Cancer Benchmarking Partnership, and one of the things we do is we benchmark and compare between countries and use that to try and learn. So what did you do that made better outcomes here than compared to Denmark? Is a very good example. 10 to 15 years ago, Denmark had very poor outcomes in relation to cancer. They then prioritized it in relation to not only there being a cancer strategy, but it being part of the overall health strategy. And then they went back into primary care and resource primary care, so you could actually get early diagnosis. And if you look now for several cancers, Denmark has exponentially improved. So it does show that having a policy based on data and then using that to inform decision making is very important. I think one of the things we need to find is that balance, that sweet spot between data privacy and the use of data. And I don't think we have that quite right in Europe. I'll give you an example that sort of tells me that maybe we need to do things slightly differently. During COVID, we had to relax the data privacy rules in order to get the data that we required to look at vaccination. And so we had to change the way we did things. If you think about it, there hasn't been a single data breach within any country in relation to those relaxation of the rules so that we could actually collect the data to allow us to develop vaccines and also to see the effect of vaccines. So I argue that maybe what we had beforehand was a bit too restrictive. I think we still need to obviously very much look at the privacy of patients, and that needs to be paramount. But given that we relaxed the rules, we didn't see any aspects of data breach, and that suggests to me that perhaps the principles that we had in place beforehand were too restrictive in relation to the collection of data. The other thing is that patients are very keen on the collection of data, but we need to find that balance. So we need to find the balance between data privacy and the use of data for the greater good or for the individual good. The other thing I think we're going to see an awful lot more of is patients collecting their own data. and having it available on their phone, and then actually deciding themselves what their data can be used for. And I think that's a really positive thing, because I think that allows us then to look at ways in which we can be really innovative in terms of collecting data, using data, making the patient the owner of their data so that they can decide what actually happens to it. So I think there's a lot to do, and the European health data space is obviously an area that we're obviously a lot of countries are working on very actively to look at ways in which we can do that. So I think we need to have that conversation more and more, rather than shying away from it and saying, oh, we don't want to go there because that's privacy issues. We need to have those conversations. We need to make people comfortable in relation to the use of data intelligence, and we need to find that balance between privacy and the better good.
If I may just add here what Mark just mentioned, we tend very frequently to forget, especially when the data is locked in some databases and then, let's say, locked, not even shared for other research purposes. But at the end of the day, the patient is always owner of that data. But it's so hard to get to it, which is nonsense.
Completely agree with you. And in terms of I just think we need to have that conversation, because I think we've sort of backed ourselves into a hole almost in relation to. And don't get me wrong, I'm very strong on data privacy, but I just think if the patient can't get access to their own data, there's something wrong with the system.
Yeah, and the thing is that then later, when we do all this meta-analysis, years later, you cannot access to the data which is relevant for everybody, and that's nonsense. I think that Europe is maybe even the worst regarding this, and GDPR and everything. I agree, it needs to be anonymized, but there's more need of data and collecting data and using real-world data. Even for answering some kind of answer in the research and trial, sometimes it could be done by real-world data, or use the real-world data for control group if possible. Because I think, Lydia, you mentioned that if you have randomized trials, how it actually goes. But do we really need that? Now with all the technology that we have and all the data that is already available. And
that's the synthetic controls we were talking about. But that brings me to another point that I just want to flag. We're not going to solve it here, about ownership of data, maybe also for surgeons. And it's not the topic of now, but I think it's important, is ownership of your tumor material, because that is a very big issue we came across with our patient information service. And there the surgeons play an important role, I think. The tumor material goes into data banks, and then if patients want to access their own tumor material, it can be a nightmare depending on the country. So their ownership of your tumor material is maybe something for Tanya and for you guys to think of one day. And I don't bring the solution, but I know it's a very important thing, and something I ask for to my surgeons about what's going to happen with my tumor material and which data bank it's going to go, and I have no problem that it's used for research and so on. But if I want to have access to it, for whatever reason, I think it should be possible, to put it very basically.
And it's also, as you said, it's very hard to follow what's happening because of all of the different systems, and anonymized data is again anonymized. That makes even bigger confusion after the trials or after clinical assessment for research. It's really a mess. Maybe technology could help us here, and the blockchain technology that gives you the follow-up, but I don't know, we're not there yet, obviously. In some parts we are, but it is a thing, and especially it's often comes on this topic when we discuss the research, especially in cancer.
I was thinking that there are so many obstacles in front of a surgeon in a not so well organized country, let's call it like this. because well, maybe they will have not so many rules on data protection, and it will be easy to use the data. But from the other side, the whole process of collection of the data and the ethical committee approval, it's sometimes a problem because you need an expert in this ethical committee, and how to find an expert if you don't have really strong research background in your country, not you personally. And then all this. But anyway, I was thinking that for young surgeons, perhaps that don't have resources to do fancy interventional research, perhaps this kind of observational studies and registries are something that they can start with, maybe to just have more
Well,
data.
the example I gave there in relation to endoscopies, for example, that was a surgical registrar who did most of that work. And it was careful collection of data and then analysis of that data. That was a really nice surgical project, that used data. And we were able to access the data in relation to endoscopies from different hospitals around Europe, around England, and that it's been quite a the paper has been quite well quoted and is used to drive the practicalities of at that time during the COVID pandemic. So certainly that aspect of things for a surgeon, to answer a particular surgically related question, but using data to do that is certainly something that I think would be attractive. And I said, very keen on in relation to the European Cancer Pulse, because we feel that we're underrepresented in relation to surgical data within that collection. So we would welcome, from your members, if people are interested in discussing, we can look and see ways in which we can get more data into that, and then perform analysis on that data. Like, it's completely anonymized data. It's not personalized at all. It's just collecting information in relation to general inequalities. So certainly happy to look at ways in which we might be able to help your junior members, particularly in that regard.
I think this is a really good point. And actually, sometimes the main problem is by sharing the data with other countries. Like when you want an international registry, the problem about the data is not just re-anonymized, but who is going to own that data? It's a safe registry, where it's going to be stored, and then who owns the data. And sometimes the problem is to be able to share the data from different countries at an international level. I think that what you have said, the point that Professor Lawler have said about what happened in COVID pandemic, that the policies were slightly improving in terms of how we use the data because we need it at that point. Maybe we should think about it in cancer and do something similar.
Yeah. Absolutely. We'd love to have a conversation with that, as I said, particularly in the context of the European Cancer Pulse. So certainly happy to follow up on that.
Yes, Carmela is writing me in the chat that maybe we have another topic for webinar.
I think so, but first of all, maybe before we as we are about to conclude already, one thing is quite clear here, that first of all, as surgeons, the beauty about surgical oncology and surgical research is that since it's very basic, although like for example the talks that we heard today are focusing a little bit more in Europe, but in fact the need for surgical research is very basic, and it's applicable for any setting all over the world. The concerns that have been shared today, although they are more in the questions that have been raised today, although they're more in the setting of Europe, in fact, a lot of our colleagues who are in the other side of the world, outside of Europe, can definitely relate to a lot of the concerns that we discussed. So I'm so happy that we had a very interesting discussion today. And indeed, this potentially new topic about the impact of data privacy for surgical research is something that we probably really need to have. And I'm hoping that if Mariela and Ruth from the ETC Transversal Group will do this webinar, it it does need a patient perspective again in that discussion.
Thank you, Carmela, very much, and thank you, everybody, for participating tonight. We have to finish our discussion, and I would like to thank first everyone who stayed till the end, because almost everybody actually stayed till the end of our talk. To give special thanks to our speakers, because you made this amazing, and I believe it was very important for everybody. And I hope we will have the chance to work soon together. I would like to remind everybody that ESSO has webinars from time to time organized, so keep an eye on our website and follow us on social media to learn more. And thank you again, and good night.